Memphis is a city fueled by hope. When times get tough, our people are always there to lend a hand to their fellow Memphian to help pull them back up on their feet. ABC 24 embraces all community efforts to keep Memphis standing tall. MAPC is a strong voice with a solid platform in the recovery community, providing aid through education, advocacy, health awareness, and networking with counseling and recovery services. We are proud to call them fellow Memphians. We are proud supporters of their mission, vision, and purpose.
Someone loses their life to an accidental overdose every day in Shelby County. But if caught in time, a life can be saved with Narcan. Narcan is a legal medication that can easily be administered to a person who has overdosed, even if they're unconscious. If you or a loved one needs Narcan, call 901-495-5103 or visit one of our convenient SafePoint Needle Exchange locations listed on the screen.
It's time to go.
I just can't believe he's gone. He was my best friend.
I didn't even know he used heroin.
He didn't. It was meth laced with fentanyl.
I wish he would have called the Tennessee Red Line and asked for help.
Overdose deaths aren't just caused by heroin anymore. Meth, other drugs, and even pills bought off the street could be laced with fentanyl. Even recreational drug use is more dangerous than ever.
It's a matter of life or meth.
My name's Jack Wyatt.
I'm John Burke.
We're with the Memphis Area Prevention Coalition. Did you know that the human brain is still developing up until the age of 25? Marijuana has been shown to impair functions such as attention, learning, memory, and decision-making.
The good news is that 75% of the youth in Shelby County do not use marijuana.
If you'd like to learn more about the Memphis Area Prevention Coalition, please visit memphisprevention.org.
Be on the winning team.
Okay, great. Hi, everyone. This is the first in-person presentation I've given since 2019. I did the summit in 2021, but it was virtual, so I'm really good at having keyboard courage. But so here I am in person with you all. I'm glad to be here. I'm going to share my presentation. Awesome. So today I'm going to talk with you all about taking a stand against commercial tobacco in Tennessee. And before we get started, I know I'm the only thing standing between you all and lunch. I don't know if you heard in my bio that I'm also a former early childhood education teacher. So we're going to start with a little, so I'm going to try to keep you all engaged as much as possible. This presentation is really for education, awareness, and then how you all can take action against commercial tobacco, specifically here in Tennessee. So we're going to get started with here are my learning objectives. And I want to, before we get started with this quick little game, I want to mention something to you that as we walk through this presentation, you may hear me mention commercial tobacco. And so there are really two different types of tobacco. There's traditional tobacco and commercial tobacco, if you weren't aware of that. Maybe you learned a little tidbit here. So traditional tobacco is one that's been used in sacred ways for centuries by Native American tribes. And it's sacred, and it really does, the use is differing. It differs from tribe to tribe. So commercial tobacco is manufactured by companies for recreational and habitual use in cigarettes, e-cigarettes, hookah, smokeless tobacco, pipe tobacco, cigars, all those tobacco products. And commercial tobacco is mass produced and sold for profit to get people addicted. So, get myself here. All right, so I don't know if you've ever played the put a finger down game, right? So someone will say, put a finger down if you this, if you that. So I don't want you all to feel like you have to do this game. You can do it in your head, you can do it, because I'm gonna mention a couple of things that might be controversial. And so I certainly am not here to embarrass anybody or make anybody feel uncomfortable. It's really just to bring awareness, and I'll get to my point here in a second. So you can do it mentally, you can do it in your lap, you can, however you feel comfortable doing that. So what we're gonna start doing is I'm gonna say what I would like you all, you can also do this, like if you're serving, clients in your facility wherever you work, if you'd like to think about it from that angle. So if you are, I'm now regretting all these animations. I'm sorry, I'm gonna get there. If you're an adult living in a rural community or area, put a finger down. So you're gonna start with 10 fingers. You only have 10 fingers, okay, right? You might need toes. Some of you may be out of fingers, unfortunately, which is, it's not a great thing. I don't really mean to joke or laugh about this. So put a finger down if you are an adult living in a rural area. If you are an adult living in a traditional tobacco growing state, so we're talking Kentucky, Tennessee, Georgia, North Carolina, South Carolina, or Virginia. So that's you if you're living in Tennessee. If you are living with a behavioral health condition, if you are under the age of 35, if you're male or identify as male, if you're an adult living in public housing, if you are Hispanic or Indigenous, if your educational level is less than an associate's degree, if you are a military veteran, if you identify as LGBTQ, if you make less than $35,000 a year, and if you're uninsured. So, as I mentioned, it was not really meant to be a joke. It was really meant to bring, to demonstrate what populations and demographics are disproportionately affected by cigarette smoking, tobacco, and e-cigarette use. And I don't mean to make you feel seen. I really just want you to understand how many people are really disproportionately affected by tobacco. So if you all were on the virtual in 2021, I share a very similar slide. I think it's really important to continue this message and conversation. Tobacco is not an equal opportunity killer, and Tennessee has really not experienced the reduction in tobacco use. And when I say tobacco, I also am including e-cigarette use, smokeless, chew dip, snuff, all of those products. So we've really not seen a reduction like other states in the nation. So the American Lung Association does a report, basically a state report every year. And as you can see, Tennessee has failing grades across the board. So for prevention and cessation funding, the CDC, Center for Disease Control and Prevention, suggests that the state of Tennessee receives $76 million in funding for tobacco prevention and cessation. My program gets $2 million from the state and a 1.1 from the federal government. So we're way off the mark there. So we definitely don't receive enough to really attack this issue. Additionally, we have a C. So actually this is an improvement. The last time I did this slide, I've had to update this slide. We used to have a D grading for smoke-free air. There's now a C grading, which so we're moving up. But there was recent legislation passed allowing bars and restaurants to prohibit smoking. Now it's not across the board. If you paid attention to the news at all, Nashville just recently passed a prohibition of smoking on, so all the bars in Nashville, on Broadway are all smoke-free now. And our coalition is doing some really great work across the state to go community to community. Really, we're working on the metropolitan areas to share this message and make people aware that this law can be passed. We know that Shelby County is going to be probably one of our hardest battles for sure. There's a lot of work being done with the Knoxville right now and getting that smoke-free air bill passed. So more to come on that. We definitely have the lowest, we're really, I think we're 43rd, yeah, 43rd in the nation for the tax rate that we had. And Kate and Ashley mentioned tax increases, and tax increases really is the leading driver of driving down smoking rates. So when you increase the taxes, we definitely would see, so we're at 62 cents, and there's no tax on e-cigarettes right now. There's some legislation going through right now, but it's probably not going to be passed. But so there is no tax on e-cigarettes, which is kind of a shock to a lot of folks. And then for access to cessation services, we receive an F grade, mostly because there are still some barriers for Medicaid, and the state does not invest a whole lot in cessation efforts. I think 46 cents per smoker is what's invested. So it's kind of bleak. around tobacco and tobacco use and smoking rates in the state of Tennessee. We were 46th, we've dropped, so that's 47th out of 50. So for smoking, and this is specific for adult smoking rates. So it does seem kind of bleak, right? I'll get to some more positive things here in a bit and some ways that you all can take action in your work and in your personal life as well. So I want to just talk just a little bit about this map. As you can see, I have highlighted Shelby County, Davidson County, Knox, and Hamilton. Those are really our largest cities in the state of Tennessee. You can see that those, so as you look at the map, the lighter is actually more improved, like lower smoking rates. So all of our major metro areas have an estimated smoking rate of 19%. And actually, Shelby County's went from 20% down to 19%. And it's not, it wasn't necessarily a huge statistical difference, but it has dropped a little bit there. So you may not think that this sounds like a very high smoking rate, but in all actuality, the national average is 14%. And there is one county in the state, you might be able to guess which one, very light county, has the very, is doing the best, I would say, I guess, with smoking rates. And that's Williamson County, and they're 13%. So there's one state out of, or excuse me, one county out of 95 that is about middle of the pack for the entire country. So it's, adult smoking is still a very big problem in the state of Tennessee. And it's something that is unfortunately not getting better. And then we're now addicting younger and younger people with e-cigarettes, and then they're switching over to tobacco, combustible cigarettes. We'll get to that in a little bit as well. We can make assumptions about why maybe those metropolitan areas are lighter than the surrounding rural counties, mostly because we can make an assumption about access to better healthcare, greater resources than in those rural counties. And so we do see that in those larger or metropolitan areas, there are greater services. So as you look, there's a band between Davidson County and Shelby that is pretty dark. And that's because it's really a much more rural part of the state. So, and then in the Northeast as well, just a lot less access to resources. So this is kind of a hard map to look at, but it's really just wanted to kind of touch on, this is the, it's from the BRFIS, Behavioral Risk Factor Surveillance System. We call it BRFIS. This is a map of the Memphis Metropolitan Statistical Area. It does include Memphis proper, and then some neighboring portions of Arkansas and Mississippi. I'll get through this data part in just a minute. Y'all just bear with me. Somebody on the last, I think Ashley said she really likes data. I know Tony Jackson, you're a data guy. So I just wanted to kind of just share, just kind of set the stage for what the issue is. So we do know that the smoking rate in Memphis is actually 17.1 for this map, right? So there's really not a statistically different, it's not statistically different from the 19.7 that is of the entire state. All that to say, there is actually a lower smoking rate among African-American smokers in the state. Unfortunately, they experience a higher rate of smoking-related disease and death, and we'll talk about that in a little bit as well. But so I just wanted to share this map just to kind of show you specifically for Memphis and the surrounding areas. But what we really need to look at and talk about are tobacco-related disparities and what they are, what that means, how different populations are disparately affected by the use of tobacco, by tobacco growing, all of those different things. So again, regretting my decision to use animation here. Tobacco-related health disparities are differences in health stemming from tobacco use and exposure. These groups that are really experience disadvantage at a higher rate are African Americans, Native Americans, people who identify as LGBTQ, people with behavioral health disorders and conditions, and then people with lower income. And then tobacco-related health disparities result from differences in use from social and environmental inequalities that impacts how use affects people. So these are the reasons behind disparity. Really, that we're going to dive into here in just a bit are tobacco industry targeting of vulnerable populations, some community-specific stressors, individual and intersectional stressors, and then social norms. For today's presentation, I'm really going to focus on the African-American population, behavioral mental health, folks with behavioral mental health conditions and diagnoses, and youth and young adults. So for decades, the tobacco industry has regularly used African-American culture as a way to boost sales. They have poured millions upon millions upon millions of dollars into targeted marketing campaigns to get minorities, especially African-American youth, to begin this potentially deadly addiction to smoking. So as you can see on the screen, they aggressively market menthol flavored products. And you may be wondering about the menthol ban that has been proposed. And that is a ban that's going to still take multiple years before it actually gets passed. So it is there, FDA is working on it. And now that we have a new director of the Center for Tobacco Products, we're hopeful that they will move along more quickly, but certainly takes a lot of time to get bans like that into place. And then again, major cities, there are up to 10 times more tobacco ads in Black neighborhoods than in any other neighborhood. And at this point, there are no restrictions on retail density. So there can be tobacco stores wherever they want to put them up. And then when I say tobacco, I also mean vape shops. So vape shops pop up all over the place. There's no regulation on that. There's also no regulation on advertising on e-cigarettes. There is on combustible tobacco products. But just some things to consider, that the industry is really the driver behind a lot of the disparity for tobacco use in specific populations. So I also want to talk about the industry targeting of the behavioral and mental health population. Tobacco marketing is an environmental determinant contributing to higher smoking prevalence among individuals with mental illness. Internal tobacco industry documents showed that companies like RJ Reynolds created market segments for groups who smoke for mood enhancement, or stress relief, anxiety relief, or to gain self-control. And they've really been targeting people since the 1950s, this specifically folks with behavioral health conditions. So it's interesting the tactics that they use, but they have truly spent millions of dollars really pinpointing how much menthol to put into these products to get people to tweak their addiction, to make it even stronger. They've used the amount of tactics that the industry uses, they have, it's never ending. And they're actually continuing to use that same playbook. So the same playbook that they used for combustible cigarettes for years and years, they're now just using these for e-cigarettes. So e-cigarettes, I'm going to throw this out there too. As a public health professional, I'm going to just offer this up to you all as an option to change our language or the way that you talk about these products. So the tobacco company in the industry, the tobacco companies, excuse me, they still use the word e-cigarette, but honestly, most of their PR and marketing, they really favor the term vapor and vaping, because this distance themselves from the products of conventional tobacco. And so they're really trying to convince people that they're safer, that it's not the same as commercial tobacco products. And so they say vape and vaping. And I know that that's kind of all of our language, right? It's not a bad word. It's just an industry term. And so I challenge you to change the way you talk about these products, especially as a public health professional, or if you're a college student who's an up-and-coming public health professional, the way that you say things matters and it makes a difference. So just something to think about. So at this point, you all know the story, right, of how all these kids got, they were targeted. These are pictures that y'all have seen everywhere, I'm sure, at this point. Pretty shiny colors and flavors, plastered all over the place. There is no, I'll repeat, there are no restrictions on e-cigarette ads. They can be anywhere. They're all over the place. And traditional combustible cigarette ads were outlawed in the 70s. So they're really just using those same tactics that they used to get people addicted long ago. So Just something. There are also no flavor restrictions in the state of Tennessee. There is a federal restriction, but as far as our own state laws restricting menthol or any other flavors, they don't exist. And then we're going to talk about just commercial tobacco use in communities of color. Menthol products are given more shelf space. And they are usually cheaper in retail outlets within African American and other minority neighborhoods. Another industry tactic, they give coupons, they reduce prices there. And if you walk into any store, there are no guidelines about advertising in stores, so they can have signs all over plastered, right? They can be next to, I know some of the prevention coalitions do those environmental scans, and they can have cigarette ads right next to the candy aisle and all these things. There are no restrictions there. So again, another tactic that the industry uses. As you can see, the tobacco industry, they're terrible people, and they really I'm taking a stand. They're terrible. I saw a laugh. They are. I'm also very passionate about it, and I just want people to know that they manipulate and take advantage of our young people, communities of color, those with mental behavioral health, diagnoses. They're the worst. So anyway, the other thing I wanted to say is, they'll give money to HBCUs. Probably many of you heard about the jewel money that went to Meharry a couple of years ago. And it was for the building of to build a beautiful facility for research. Unfortunately, a lot of that research is going to be tainted because it was funded on the backs of tobacco, right? So that's something that is hard because HBCUs are struggling. They need the money. And then they're offered all of this money from Jewel. Now listen, I'm here to take some Jewel settlement money. I'll take it. But that's a different kind of money. He's laughing because he understands. So it's just something to consider and think about, that all of these different health disparities and these different populations that experiences disparities at a different level all started with the industry. And so I'm trying to encourage you to hate them as much as I do. I hope it's working. Good. I hope I'm firing you up. So behavioral health and commercial tobacco use. So let me just say, before I get into this slide and this discussion, I want to preface this by saying I'm here as an advocate and a support for change for this population. I'm here to provide information, consideration, and education for educational purposes. I know that tobacco is not your priority when it comes to working with clients, patients. I totally understand that. But I am also here to improve those health outcomes for your patients and their clients. So some things to consider, especially if you work in a behavioral health or a mental health substance use facility. Just hear me out. So on your screen, it does say approximately 1 in 4 adults in the United States have a behavioral health condition. And these adults consume approximately 40% of all the cigarettes smoked by adults. That's a really high number. And nicotine dependency rates for individuals with behavioral health disorders is 2 to 3 times higher than the general population. So they smoke at a really high rate. And if they're not smoking, they're probably vape, using e-cigarettes. Catch myself, and that's okay. It's really about awareness, guys. So, among current smokers with a lifetime history of depression, anxiety, and major depressive disorders, they smoke more cigarettes. They smoke more frequently. They smoke at a much higher level, and they have a really high level of dependency. Individuals with social anxiety are more likely to engage in heavy smoking. They're also less successful in quitting in comparison to individuals without social anxiety, depression, or other substance use disorders. More than 80% of youth with substance use disorders report current use. And many of those kids, those young people, become highly addicted, and then they're long-term tobacco users. So it's a big problem that I know that you all know exists. But I'm going to share some ways that you can consider making some change within your organization or within the way that you work with your patients and your clients. So a little bit just kind of about just consider the thought. These are actually data points from the American Lung Association. So 70 to 80% of individuals receiving substance use disorder treatment have expressed an interest in tobacco cessation. So they come in, they get screened, and they are asked, if they smoke or if they vape or use e-cigarettes or whatever it is. And they do express that desire to quit or to get some support quitting. And then participation in smoking cessation efforts while engaged in substance use treatment has really been associated with a 25% greater likelihood for long-term abstinence. And individuals living with behavioral health conditions are just as likely to want to stop smoking, but often lack the confidence in their ability to quit, and historically have not been offered the resources or the specialized support to quit because it's not an immediate threat, right? So I think just considering and thinking through their desire to quit and how you can support that is what we're going to talk about in just a little bit. So now we're going to talk about youth and young adult e-cigarette use. And when I say young adults, I mean the 18 to 24-year-old population, which is really the very hardest population to reach, to get a hold of, to have them understand the dangers of using these products because they are 10 foot tall and bulletproof. No, I used to be that way. Flavored products are really still driving youth use. Current e-cigarette use has not improved or declined since really 2015, when this data was we started tracking the data. The rate for current e-cigarette use is 19%, which is and same as the case for experimentation with e-cigarettes, and we've not seen a major decline since 2015. It may not sound like a very high rate, but it's higher than the national average. So the current rate is, let's see, those that experiment is 39.5, so about 40% experiment with e-cigarettes. Older high school students are much more likely to be current users or have experimented with e-cigarettes. Non-Hispanic Black students are less likely to be current users than their non-Hispanic white counterparts. But the thing I want you to think about is that these rates carry over into adulthood. So if you think about adults that are under 35, adults that are under 35, we're really focusing on kind of that 18 to 30 or 18 to 24 population are the primary users of e-cigarettes if we're talking about e-cigarette use in adulthood. So we know that the problem is not really adults, but of the adult population, it's that one little, the group, that one 18 to 24-year-old group that we're really most concerned about. And so these are the kids, we can assume that these are the kids that in 2015, when these products really hit the market, that these are the kids who are still using these products, right? They're still addicted. They're still having, they're still using these products at a really high rate. And youth in general use these products at about 2 times more, that rate, 2 times higher than adults. So they're not just experimenting with e-cigarettes. Many of them are smoking these every day. They're, that's the sign that they're becoming addicted. And then there is a very large body of evidence that shows, and we'll talk about this on the next slide, that their transition from e-cigarette use to combustibles is a quick transition, and they're then becoming lifelong smokers. And kids, so they've shifted dramatically from using, because Juul came off the market, but they now use disposables and then menthol e-cigarettes. And menthol is still a flavor, guys. It's still a flavor, but it wasn't taken off the market. So mint and menthol remain on the market. Let's see. So really, if you think about it, they first get addicted because of all these delicious flavors. They leave mint and menthol on the market. They're still using these products. So in my mind, the only way to really get out of this crisis is to remove all flavors, which would include mint and menthol, which is really going to make a huge difference when they do finally get the menthol ban into place. Like it or not, I'm excited to see that happen because I truly think that the rates of menthol use in African-American populations will drop drastically, and we'll see some major improvements in health outcomes. So, like I mentioned, there have been multiple studies on the topic of the transition of youth from e-cigarette use to combustible cigarette use. And that is, they're 7 times more likely after 1 year. So after 1 year of using e-cigarettes, they're 7 times more likely to be a lifelong smoker of combustible cigarettes. Just to put that out there, they're not, a lot of kids are not just experimenting, they're becoming addicted and then being stuck with them, with this addiction. So this is a quote from the Surgeon General. The U.S. Surgeon General has concluded that youth use of nicotine in any form, so any e-hookah, dip or chew or snuff, cigarettes, e-cigarettes, all of them, it's unsafe for young people. Nicotine is highly addictive. It's a highly addictive drug that can harm the adolescent brain. I think that's the message that we have to continue to just push forward. So we'll have a conversation in a second about adult use of these products, but for young people who would never, ever have picked up a cigarette and they're turning around and using these devices, it's mostly about the nicotine use on the developing brain. We know that young people's brains don't really finish forming and developing until they're 25. And so you put those products on top of a developing brain and they already have a hard time making decisions, right? So I think that's the message that we as public health professionals need to continue to push out, is that on a developing brain, no level of nicotine is safe. Okay. So there is clear evidence. So there is evidence that e-cigarettes are beneficial to adult smokers. If you are not pregnant, and if you do a complete transition from a combustible cigarette, hear me, because I'm not saying just adding e-cigarettes. If you do a complete transition from a combustible cigarette to an e-cigarette, you absolutely are improving your chances at reducing your risk for lung cancer, all of those different tobacco-related diseases. You're certainly giving yourself a better chance. Now, if you're pregnant, absolutely you shouldn't be using any kind of nicotine. But if you're a smoker who had been smoking for 10 or 15 or 20 years, you're definitely going to see some improved health outcomes. But again, not necessarily the case, absolutely not the case for youth. The bottom line is we have made incredible progress over the last 10 years to really reduce youth smoking rates. And unfortunately, all of that work is being reversed because of the e-cigarette use and this generation that would swear up and down they would never smoke a cigarette. And they're just very highly addicted to these products at this time. So just something to consider if you're ever talking to a young person and they think they're safer. They are safer if you're an adult who's been smoking for many, many years. So we're going to switch gears here and talk about some opportunities for policy intervention. Sorry, I hope that I don't let you sleep through this. There's actually some really interesting ways that behavioral mental health facilities can get involved in some of this work. So as I mentioned before, 1 in 4 adults living in the United States has some form of behavioral health condition, and they smoke at a really high rate. That said, over the past few years, my team has been working to assess and identify some gaps in tobacco policy for behavioral health facilities across the state. The things that we're looking at really closely is whether or not a facility screens for tobacco use. As you can see on this very far left, so the blue is mental health facility and the red. And so all this data also came from SAMHSA. This is, I should have had my source here, sorry guys, but it's all from SAMHSA. And then we have created several different graphs and documents. Happy to share those if there's interest. But we see that screening is very high. It's very high in both mental health and substance use facilities. It's that question, do you smoke? Do you use any tobacco products? We also take a look at whether facilities offer counseling for tobacco cessation on site, or NRT, which is nicotine replacement therapy. That's the gum, the patches, the mints, any of those. 5 FDA approved, because e-cigarette use is not approved for cessation. Just thought I'd put it out there. So anyway, they do, we are just kind of looking and assessing those policies across all facilities. And then whether or not, this is the hardest one, whether or not there's a smoke-free campus. We absolutely recognize that tobacco cessation is not a priority. I'll say it again. It's not a focus because it's not an immediate threat. But it is certainly something that you all still, the prevention coalitions, and everybody still has a focus on. You still see patients that probably do report that they smoke and use e-cigarettes and all these things. And if there's an interest on their part to quit, that's where I am going to suggest that you maybe jump on and address that need. So we at the Department of Health and our counterparts across the state in all 95 counties, we fund a tobacco coordinator and health educators across the state. You'll have a fantastic group right there in the middle from Shelby County. They work on tobacco prevention and control work, but they are working with their community partners to see how they can assist with policy change. And so here's what I'm going to say. I'm going to try to make it as easy as possible. And I know it's not really an easy concept. So we know that screening is really that very simplest. So asking the question, right? So getting a policy in place, it's that policy, systems, and environmental change, right? So you want to make a big change, you start screening folks. Okay, so then they say, I'm really dumbing this down, guys. I'm making it very simple, and I understand that it's not quite this simple, but it's something to consider talking with your management administration about. So the other thing is so what do you do if they say that they want to quit? Do you offer cessation on site? Do you offer cessation counseling? I understand it's not their immediate threat. That's not what you need to address first. But if they do say, hey, I'm interested in quitting, are you able to offer cessation on site? It's reimbursable. It's codable. You can get reimbursed. That's a service. So if you're thinking about your bottom line, that's certainly something to consider if your facility is not offering that. The next thing is NRT. Do you offer NRT on site? Again, it's reimbursable. If you're just thinking about it from your bottom line and trying to make extra money for your facility, super. If you think about it from your patient's point of view, also super, because then they're addressing all of their addictions there at the same time. One of the very hardest policies we understand to get passed is tobacco-free campus, but it is incredibly difficult for a former smoker or someone who's trying to quit smoking to go into an area or be exposed to tobacco smoke. And it's hard to take that last thing away from them, right? I get it. I mean, I don't personally get it, but I understand. So it's easy for me to stand up here and say, you should really put these policies into place and make these changes, but it's something to consider. And I've got an opportunity for you all. So the last thing I want to say about behavioral health and mental health policy changes, that the Department of Health applied for a really fantastic opportunity working with SAMHSA and the University of California, their Smoking Cessation Leadership Academy, to provide technical assistance and help folks like you all who work in behavioral health facilities or work with patients who do smoke, to learn how to make these policy changes, to help improve the health outcomes for those individuals living with these diagnoses. And so we have an opportunity this August. We're having a 2-day summit where folks can come together and really learn from the experts, because I am not that on policy change. But I'm inviting you all, if you're interested. My email address is at the end of this presentation. If you're interested in learning more about policy change at within your facility, please reach out, and I would love to chat with you about that opportunity. It's fully paid for by the state of Tennessee and SAMHSA. So if you're interested in learning more, let me know. Okay. So what? 30. Okay, I'm gonna be very quick. Yeah, actually, this is the last 2 slides. So opportunities for policy intervention within K-12 schools. If you are with a prevention coalition, you may have seen this. We've shared it widely. We have a fantastic toolkit. You can probably just Google it instead of trying to get that link. But it is a toolkit that supports alternative suspension. It supports schools putting policies into place that protect students from just being booted from schools if they're caught with tobacco or e-cigarettes. It is a very supportive method to approach to supporting kids in their cessation efforts instead of just kicking them out and saying, or citing them, all those things. We've seen all of the different options from different school policies. So that's a great resource. There's also one for higher education institutions that we did not create, but it's with from Pennsylvania and the American Lung Association. If you are with a higher education institution, it's a super resource. This is my last slide, and then I've got my contact information at the end. So we always want to promote evidence-based quit support services. These are, I'm always going to promote the Tennessee Tobacco Quit Line because it's one of my programs, but it is a free phone counseling, and you receive, if someone calls, they're offered up to 2 weeks, which I know isn't much, but 2 weeks of free NRT. If you're 18 and older, you get counseling calls from master's level counselors. There are tobacco treatment specialists as well. We also have a texting service that is only for 18 and older at this point. We are working through some kinks with our vendor. But there is a vaping, it's with Truth Initiative. They have a vaping counseling texting service where young people can call and get some support there. If you don't know anything about the Baby Me Tobacco Free program, it is offering all 95 health departments, and it's really to support women and their partners quit attempt during pregnancy. It's an incentive-based program, so they attend counseling sessions, they quit smoking, they get vouchers for diapers and wipes. So check it out. If you don't know about that program, Shelby County has a very robust Baby Me Tobacco Free program. Lastly, I will just mention this Quick Start app that is it's a free resource for iPhone and Android. You can definitely check that out if you're interested in sharing some resources for cessation. Look, I know y'all are hungry. I am too. So anyway, I tried to catch you up, John. It's 12:31, y'all. I think I did it. So anyway, here's my information. If you need any